significant for a quick comment because it should be pointed out that amongst the federal partner agencies, only the Department of Defense mince breeds, trains, and provides a full career path to people who are titled as medical planners. And part of the reason why I became so heavily involved in the post 9/11 era with so many of the strategic level plans that were created for the United States to respond to high end incidents of national significance uh, were brought to the table in the DoD for us to help the agencies address at the most senior level. So with that in mind, I'm going to take my perspective now with some 35 plus years in this space of medical planning, primarily for not only incidents of national significance that occur on the terrorism side, but also large scale disasters and especially disease events that could qualify as pandemics. So with that in mind, let's go. All right, we're not advancing. Let's try this. Here we go. So here's the normal statement about attribution. Everything that you see today is available for attribution. I would respectfully ask, though, that you observe the fact that the material is copyrighted because I have published most of it in one form or another, either in book chapters or peer-reviewed journals. So if you're going to use it, I request that you at least appropriately represent me as a reference. I need to say for the record, though, that these comments today represent my opinion and my opinion alone, and are not to be construed with the three organizations that I remain principally involved in, that being the George Washington University, the New York State Division of Military and Naval Affairs, and the Marshall Center for European Security Studies. So I thought it would be a good idea to start off with creating a definition for pandemic. And I put the question mark up here against the title of the slide because one could argue that in the last 25 years, especially, that definition has had its own sliding scale. A lot of it being driven by the politics of public health that we have seemed to have to wrestle with on a fairly frequent basis now. So with that in mind, we started hearing about pandemics in the general population, I would suggest around the 2005 and 2006 timeframe, when we started becoming very concerned about what everybody should be aware of now, and that being the avian flu, which is the H5N1 variant of human influenza A. We're going to talk about that in some deeper depth more further into the presentation today. But according to the standard Merriam-Webster College Dictionary definition, the word pandemic is derived from the Greek pandemos, which means for all of the people. The broadest definition is that a pandemic is a disease event that covers a very wide geographic area and affects an exceptionally high proportion of people. Other acceptable definitions that we've seen emerge, the last one being the one that I think prior to 2005 and 6 was the most generally accepted definition, that it's a disease outbreak that has spread simultaneously to 3 or more continents around the world, and could easily be qualified as an epidemic that is occurring worldwide. We again are going to talk about this notion of how fast diseases spread, why we have more concerns about pandemics in the modern age, and how that definition is changing sometimes on a very quick basis. But with that in mind, let's get the big elephant in the room out of the way first, and that's smallpox. Throughout the presentation today, you're going to see the covers of various books that I offer as exceptional references that you might consider doing or looking at. One of them is this book that came out, I believe, in the 1986 timeframe, written by Donald Hopkins. It's a tremendously good history, a lot of numbers, and the numbers are one of the things that's important to know about smallpox in the first place. I maintain that smallpox is one of the diseases in all of history that might be qualified as being an ongoing pandemic that has lasted for more than 2 millennia. It certainly meets the requirements of the definition that it has occurred while it was still an active disease amongst the human population on more than three continents simultaneously at almost all of the given time that smallpox was still endemic to the human population. The very earliest evidence of the disease that we have dates back to before 2500 in the Common Era. That's part of the early Egyptian dynastic periods. We got the evidence of smallpox outbreaks mainly from our colleagues in the field of Egyptology, who, in the course of uncovering some of the buried pharaohs and various mummies that were left behind by the great Egyptian civilizations, noticed that some of the oldest ones of the mummies had very readily apparent smallpox scars, or the classic pitting that you normally see on a smallpox victim's face. It was, as I mentioned, endemic on every continent and reported by virtually every major civilization that has come through the course of time. In fact, it was such a big deal to many of these civilizations that they created gods, not only of it in its honor, but also in its fear. Many people created these gods with the sole purpose of praying to them to reduce the horrendous suffering and death that normally came with this disease. If you know nothing about smallpox, if you're starting off on a greenfield slate, if you will, about it, it's one of the nastier diseases that the human, if not the nastiest disease that the human race has suffered through and with for all of this time. Creates unbelievably horrible and painful symptoms and side effects, and it kills roughly between 20 and 30% of its victims. That is what we refer to, by the way, as the CFR, or case fatality ratio. The numbers over time are nothing short of staggering. If you read this book, and again, don't get caught up in just the numbers that Dr. Hopkins is presenting. What you realize is that cumulatively, as you go through the pages, and it's broken up by the sections of the world and some of the great empires that have had records of smallpox, to say that smallpox has affected and killed in the billions is not understatement. It's absolutely true. And because of it, wars were lost, empires have ended. Some argue that the great Athenian Empire, for example, during the Peloponnesian War, as sort of a starting point of its impact on history, was one of the countries or empires that smallpox helped precipitate its decline and fall. So this has been with us for a long time. And this is one of the overarching themes of my presentation today, about how much disease and public health issues are more than just a medical and public health issue alone, that they have impactful societal, geopolitical, economic, and global impacts that have, in of course, with smallpox, literally changed the course of history. And as we'll see, we've had other events over time that have virtually done the same thing. So with smallpox out of the way, let's start our discussion with influenza, if only because I said in the prequel or overview of this presentation today that we were going to look back over pandemics in history, but only in about 100-year time frame. This is another great book that everybody in the medical and public health field should have. Dr. R.S. Bray was a British medical historian, not a physician, a PhD, who provided one of the best, if not the best, overviews of what disease has done to the human species and the great civilizations over time. He points out that the very earliest historical records related to influenza occurred in Sicily in the last millennium before the Common Era. It was referred to as the sweating sickness then. We know that there were six major outbreaks, major epidemics that occurred in the Roman Empire, which started small in the Italian peninsula, and by the time they reached their apex, uh, before the fall of the Roman Empire with Marcus Aurelius, there were six additional outbreaks up into the 900s AD that were historically of note. More generally accepted dates for pandemics start around 1170, with more than 300 outbreaks in Europe through 1875. The term itself comes from the French grippe, or gripper, meaning seizure or grasp or hook. If you've ever read, some of the books by people like John Barry and Gina Colada that I'll talk about in a minute that exclusively covered flu, that grip will make sense because there's anecdotal reporting, especially from the 1918 and 1919 pandemic, where people would be standing on the corner of a street, suddenly turned acutely cyanotic, collapse, and die. So it was if someone unseen had grabbed their throat, restricted their ability to air, to oxygenate, turned them blue, and immediately caused a very rapid deceleration to death. The first time we see the word influenza, actually, or something like it, comes from around 1580 in Florence during another major outbreak or epidemic that Dr. Bray covers. Influenza, by the way, in this particular book, just to give you a note on how important it is in terms of its impact in history, is the only disease amongst the many he covers that has two separate chapters devoted to it. So that's a marker right there for its significance. With that in mind, we're going to go right to the 1918 and 1919 influenza pandemic, which was erroneously called the Spanish flu. I'll come back to that in a second. This was considered the single deadliest disease outbreak in recorded history. The nearest comparison, for those of you who like history and follow its course, in the realm of public health, would say, well, what about the Black Plague, which occurred in 1346 and 1347? That killed an estimated 75 million people worldwide, mainly in Central, Northern, and Southern Europe and the Near East. But the mortality for the global impact of the 1918 and 19 influenza pandemic started at around 22 million people when they were doing lookbacks on the M&M, or morbidity and mortality, in the 1920s and 30s. But Oak Ridge did a significant, Oak Ridge being one of the national laboratories, did some very significant modeling in the early 2000s, right around the time we were becoming very concerned with the rise of the number of cases of avian flu related to H5N1. And they believe it's closer to 100 million people relative to the number of deaths that were caused by this worldwide. Globally, the attack rate of the entire human population was between 40 and 50%. Keep this number in mind. At the time of the Spanish influenza, the global population was 1.8 billion. I'm going to come back to that. And I've already mentioned this notion of the case fatality ratio for the Spanish flu was between 0.5 and 1 to 2% globally, although some of the populations who had never had an exposure before, such as the Samoan Islands and some villages above the Arctic Circle that were home to Eskimo populations or indigenous Indian populations in that region, had mortality that went up to between 25 and 100% of the population because they were a greenfield population. They'd never been exposed to this type of disease before. And when it whipped through their population, it was a major killer. There was a previous pandemic in 1889 and 91 that had three distinct waves. And I always found how they qualified these waves in history. These were the actual terms that they use. The first wave that occurred between February and March of 1918 was considered a bad wave. The second wave that occurred started in the late summer of 18 August through October was a really bad wave. Actually, John Barry writes in his book, The Great Influenza, that it was a really, really bad wave. And then the February 2019, by February 2019, the third distinct wave was labeled a resolving wave when people started to demonstrate global herd immunity against that particular strain. Remember at the time, although we did have vaccine available as a process back from the late 1700s, as discovered by Edward Jenner, using small cowpox to first inoculate and later vaccinate people. There was no vaccine available for any type of influenza at this time, so that was not a solution to help reduce its overall impact as it progressed through the human population. I mentioned already that it was erroneously thought to have originated in Madrid, Spain, and hence its dubbing or title as the Spanish flu or the Spanish lady. That happened because of what was going on at the time. And here's what we're really going to start factoring in history. If you're a good historian, you'll know that in 1918, we were pretty much at the apex of World War I, at once time considered to be the war to end all wars. I'll come back to that in a few minutes. In fact, the outbreak or the index case or initial index cluster occurred here in the United States at an Army camp called Camp Funston in the state of Kansas. Why it ended up getting this moniker of Spanish flu or Spanish lady is hypothesized to be over the fact that most of the Allied forces that were being sent to Europe to do battle with Germany were massing in Spain and some of the countries west of the Maginot Line at the time, which was largely in central France, that separated where the Germans were fighting the Allied forces. So because the cluster grew most significantly with all of these people who were waiting in Spain to be deployed to the front, originally many people thought that that's where the flu had originated, but we know now that that was not the case. The Spanish flu outbreak was caused by the H1N1 variant of influenza A, and the flu in this case caused what's known as a cytokine storm in the healthiest people. Because first of all, a cytokine storm is, for lack of a better or more complicated way to explain it, is really your immune system run amok. When challenged by some sort of pathogen, it sends the immune system into overdrive, and people would end up having a very rapidly developing fulminating viral pneumonitis that would progress to respiratory failure and death. If you're knowledgeable about flu in the first place, seasonal flu usually affects the pediatric populations the worst, and the geriatric populations the worst. That means our very youngest and oldest populations, many of whom had co-pathologies that would not be helpful if they were faced with some type of immunological threat in the first place. But in this case, the healthiest population, the 18 to 45 demographic, was the group that really was hit the hardest in terms of not only morbidity, but mortality. And the general rule of thumb with the influenza A pandemic in 1918 and 1919 was the healthier you were, the worse that this was going to be. And that has carried over for the same hypothesis in terms of other 20th century pandemics and any future pandemics that we have. Just kind of a tongue-in-cheek note, I was giving a presentation along this line to a fairly large group one day, and I saw a woman who was in one of the front row seats who was actually squirming in discomfort about hearing this. And I hear her say a little bit under her breath is, "Man, I'm gonna start smoking and drinking heavily tonight." And apparently she was a runner who was working hard to keep herself safe and healthy. But when she heard about this, she realized that those efforts might be the very thing that would cause an individual's demise. The flu was diffused, quote unquote, as fast as a man could carry it in most of the literature. And at the time, I want you to think of what the most common lines of communication, which is a euphemism kind of for how the military refers to lines of transportation. It just means that this is how people got around. At the time, the predominant ways of people moving around the world, both intercontinentally and intercontinentally, were rail and maritime platforms, respectively. So if you think about that, both of those move relatively slow compared to modern forms or modalities of transportation. And we're going to come back to this because this is a very, very important point about future concerns for pandemics and major highly pathogenic and virulent disease outbreaks. I also want to point out that because we used rail and maritime platforms, especially at the intercontinental level, the use of quarantine was much, much more effective than it is now. In fact, there's healthy argument going on to this day, especially in the wake of the recent COVID-19 pandemic, about the utility of quarantine when we're looking at a highly, again, virulent and pathogenic disease that is spread largely by particulate respiratory matter, where people have a latency period where they remain asymptomatic. So with that in mind, you can throw out the notion of containment because people will break the containment barrier before you have enough significant notice of the spread of an outbreak from any recognizable index cluster or case. And hence the same would apply to quarantine by the time we would impose quarantine mainly at the littorals or ports of entry into our countries. The utility of the initiative might be self-limiting. By the way, for future reference, this term PAR that I'll use pretty frequently in this discussion stands for population at risk. It just refers to the population at large that might be affected by any significant disease. To say that the impact of the influenza pandemic in the early 20th century was profound is gross understatement. And here's just a couple of pieces of the tail of the tape, as they say in the boxing world. First off, it killed more people than the entire First World War, which, again, as I noted earlier, was labeled the war to end all wars. And this included both the military populations that lost their lives and the civilian population, which was in fact much larger than the actual military personnel who were engaged in the war directly. The numbers totaling about 40 million, but even those might be slid a bit to the right. Some people argue that that could be as much as 60 million. Nonetheless, it was a lot of people, and it had a horrific effect on the world at the time it occurred. Some historians have argued that the outbreak was so bad that it actually led to the German capitulation at the end and the end of the First War, which is one of the first times in at least recent history that we see the geopolitical impact of a disease event that's having an effect in the global national security arena. Again, I keep noting that I'll come back to things, but this will all tie together as we progress. But despite its historically unprecedented impact, the 1918 and 1919 pandemic is sometimes referred to as the forgotten pandemic for a couple of reasons. Even without historical precedent, there's very little referenceable material of the event in any genre, whether that be nonfiction, historical fiction, or historical narratives that give a contemporaneous overview about what was happening in near real time during the 18 and 19 pandemic. But as we're going to see in a second, this lack of a good accounting that occurred is not by serendipity or paucity of interested historians. This was very purposefully done, primarily by a single individual, at least here in the United States. I throw up the covers of these three books because from at least a fiction perspective, if you are a library person who goes and likes to look around for pertinent subject material in areas of interest like pandemics. These are largely the only three that you will find as prominent historical fiction. Pale Horse and Pale Rider probably being the most famous by Catherine Ann Porter, pretty short book, and Thomas, which was written in the 1920s, and Thomas Wolfe's work of fiction, Look Homeward Angel, which was written later, 1930s, but involved the impact on a town and a particular family while the influenza pandemic was going on. The Last Town on Earth is a late 20th century, I'm sorry, early 21st century work of fiction written by Thomas Mullen that kind of follows Wolfe's approach to it in providing historical fiction. But back to my point, contemporaneously, there just wasn't that much on the time, or at the time, until the authors Gina Kolata and John Barry published these two books in 1999 and 2004. Gina's in 99 and Barry in 2004, that gave their historical accounts of the pandemic. I would argue, both. First of all, these are both very, very good books. John Barry's book is tremendously important in the field of pandemic studies, influenza studies, and understanding the impact about major disease events and what it does to both entire societies like the United States, but also the global society at large. Both of them should remind us that it was in the cover of the very first book I was given when I went to boot camp in the Navy. I'm prior enlisted, called History and Traditions of the Naval Service. In the front cover was this quote from Alfred Thayer Mann, who was the gentleman who is considered to be the founder of the U.S. Naval War College, or graduate school for the study of war in Newport, Rhode Island. He said the study of history is the basis for all sound decisions. The actual quote is all sound military decisions, but you get my point here. Probably the more recognizable quote is from Georges Santayana, who said that those who cannot learn from history are doomed to repeat it. And they're apropos quotes to put up because there is much to learn about what happened in an event of this magnitude just 100 years ago, which was not that long ago. Barry's book in particular is a very useful examination of what the pandemic did, and as those lessons may be applied to pandemics that might have occurred prior to COVID-19, but certainly before any other large-scale, mainly influenza pandemic happens. And some of the issues to look at that you'll see flow right into the COVID discussion are President Wilson and the adequacy of the government's crisis communication. In a nutshell, Wilson was the individual that was responsible for basically ordering a silencing of the coverage of the pandemic in print journalism and any other media that was available at the time. Remember, we were still in the infancy of our radio communications in terms of spreading news. Television did not exist yet at the time, so people mainly got their information from newspapers and written print material. But Wilson's concern was related to the argument that the Germans actually capitulated because of the impact of the influenza pandemic. Wilson didn't want our foes in Western Europe that we were fighting the first quote unquote world war against to know just how significant the impact of the outbreak was on our military forces. So he basically placed a gag order on things, and that may have been good for national security reasons. It was not good at all in terms of the government being able to provide good crisis communications to advise people about strategies for lessening the impact of the disease on them, their families, and their communities. And the impact, of course, as we know, was enormous, especially on the medical and public health resources that were available then. You see this picture right here, which, if we could colorize that and turn it into a modern picture, would may have been one of the alternate care facilities or sites, ACSs, that we were forced to create as surge capacity resources to deal with the large influx of the number of patients who were in demand of support and care during their illness. We learned a tremendous amount about volunteerism and how the Red Cross and other like non-governmental and private volunteer organizations could help, especially in terms of taking on some of the roles in the surge demand that our healthcare professionals were unable to provide. I'll talk about that more in a bit. John Barry suggests in his afterword, which he will tell you personally is the part that you should read of the book if you don't read any other part of the book, because his afterword talks about what our main concerns in a modern pandemic would look like, and actually underscore most of this presentation in terms of the recommendations that I will make. But he argues that amongst all of the areas of concern, and I put these in a nice bin that I've called in my own contribution to the literature the 8 pillars of catastrophic casualty care. Those being surge capacity demand, patient movement and transportation, medical logistics and supply, mass fatality management, psychosocial support to affected populations, managing special needs populations, managing public health crisis communications, and managing the graceful degradation of the standard of care. Of those 8, besides the highly recognizable one, John argues that our biggest shortfall and potential Achilles heel of things going very, very south, at least from the perspective of public opinion and our view of government, is the mass fatality management mission. People do not want to do this, and we are not architected in our current critical infrastructure and key resource sectors to do mass fatality management, because there's no organizations or people who really truly specialize in this space. And I would argue, because many people have said, well, what about the military? You're used to dealing with large numbers of deaths, not at the level of where you're having corpses having to be stacked up like firewood on street corners like they were in 1918 and 1919. The majority of our fatality management resources are in the funerary industry, and those occur at the city, town, and local level, and are not used to dealing with more. Most funeral homes do not have more than 4 to 5 deaths per month in their community to deal with. So when you get spikes in these numbers, this is a really problematic issue. And I've already talked a bit about the utility of quarantine and containment, but here is when the term social distancing, sheltering in place, and enhanced hygienics really come to the fore as the means to try and limit or reduce the spread and transmission of the disease. So I'm going to kind of shift here for a second. I wanted to show, you might think we're going back to smallpox. We're not. But this is kind of an intro slide and picture really that I thought was effective for us to consider in terms of the recent COVID outbreak, and the number of people who engaged in what I can only qualify as a phenomenon of being an anti-vaxxer. What you see here is 2 young boys who are both the same age as the slide notes, 13 years old. This picture was taken in 1901 in Great Britain. At the time, you'll see in the footnotes that, like many other countries throughout the world who were learning to enjoy the benefits of vaccine to prevent smallpox and reduce its spread markedly against what had occurred previously in history, this was mandatory. Meaning it was illegal not to have your children between largely the ages of 12 and 18 months vaccinated with the smallpox vaccine, in hopes of preventing it becoming a community, state, or national issue. Unfortunately, we have no record of how this turned out for this poor young man on the left, but as I mentioned earlier, the mortality associated with smallpox throughout history has been pretty static, between 10 and 20% of those infected Some will argue now that that might be higher in a modern outbreak that occurred under what D.A. Henderson, the gentleman who was credited with the eradication of this of smallpox during the WHO campaign in the late 1960s, has termed a global greenfield population because we don't vaccinate anymore. We stopped active vaccine programs, at least here in the United States, in 1971. DA has once in my presence, I had the fortune to meet the great man, said that in the era that is now dominated by asymmetrical threats, including bioterrorism, the fact that we no longer vaccinate against this particular disease and knowing that it could either occur again naturally or purposefully as a weaponized agent, we've created an environment of great risk. In fact, he said it could be the greatest risk in public health that we have ever faced, even in the wake of what we thought was the greatest triumph in public health history in eliminating the greatest killer in history from occurring naturally. But what you see here that I want to say is important is an example of what's known as conditional logic. That term is actually borrowed from algebra, a subject I was never very good at. But what it really means is if A, then B. So think about how this might apply. If A, you were vaccinated by your parents and by the laws and rules of your community and country, then B, you did not get smallpox. Conversely, if you were not vaccinated because your parents, in the case of this child's infancy, chose not to observe those rules, then B, you are still at great risk and susceptible to getting sick and potentially dying. So if we carry this over now to the modern era, and argue that, if we offer safe and known to be effective vaccine against an emerging pathogenic threat that has a high likelihood of increased morbidity and mortality in our community and even in the global population, how is this notion of being an anti-vaxxer of any sense in the modern era? So I again, present another book that I think is worth reading. This one is by Richard Conniff. It's a recent book, 2023, and I think what's most important about this book is he talks about another time in history. But in the case of this being another time in history, Mr. Conniff, who is a reporter, he's not a healthcare or public health professional, brings us only back to about 100 years ago or less, when we still heard routinely about illnesses and death from the diseases that I list in these two columns. If you are of a certain age, every one of these was still endemic to our community, to the United States, and to the world at large for the most part, including malaria, which was endemic to parts of the southeast of the United States, and would cause very significant morbidity, at least until we started to develop either very good vaccine and immunization programs or learned how to treat the disease itself better. But they were all typical. In fact, most of them occurred as childhood diseases, along others such as whooping cough, mumps, chickenpox, and measles that we know now we have safe and effective vaccines for, even against people who say that they cause things, specifically MMR. The measles, mumps, rubella vaccine causes autism. There is no clinical proof that that's the case. Could be a whole separate presentation and discussion. But the anti-vaxxers have raised the concern that some of these diseases may, in fact, be coming back, and some of them are. We are seeing increased numbers of measles cases in the United States and abroad, and that should be of concern to everybody. But if you are closer to a person like my age or some of the other people on this call, you can count off, some of these diseases by how close, you escaped contracting everyone or attracting every one of them. all too recently, as 1952, before the Salk vaccine, polio, which was a scourge among childhood populations, right up until this very year that the vaccine became available, caused paralysis in 21,300 people in 52 and killed 3,150 of them, vast majority of them being children. Still by 1963, measles was affecting more than 350,000 American children on average, killing more than 440 of them before the arrival of the vaccine. By the way, as you see in the footnote, this is important to remember. Just 60 years ago, 2 years ago after I was born, it took 10 years to develop the effective measles vaccine that stopped that disease dead in its tracks. And as you'll see in a minute, that particular paradigm in terms of coming up with an effective vaccine for a newly emerging disease, which measles wasn't, has shrunk so markedly that it's a good indicator of the advances of science and technology that are available to us now as something that works to our favor in terms of combating emerging diseases. By 1974, on the very brink of the eradication of the smallpox virus, it was still infecting 220,000 people worldwide, and by then killing 30% of them, which leads to the so-called rule of 30s, where if we saw a modern outbreak now, 30% of the population would die from it, 30% would become blind, which is a common side effect of smallpox when some of the pustule material is rubbed into the eyes. 30% would survive but be horribly scarred, which led to enormous numbers of suicide in the pre-modern era. And then for some reason, 10% we think would survive because they were benefited by genetic herd immunity that had been passed on by previous family members who had contracted disease and themselves survived it. But with that in mind, when was the last time anybody, who's on the call today heard about blood poisoning from a splinter or even knows about the term lockjaw that could have been contracted by stepping on a rusty nail, for example? When I was a child, these were real threats that existed as closely to us as our schoolyard. And that parents were always warning us to be of care of so that we would not ourselves fall victim and either get very sick, require significant medical treatment, or potentially die. So the rhetorical question that I have to ask with all of this, as a lead up, is with all of this in mind, how is it that even within 100 years, when we have thousands of years of historical evidence about the impact of disease upon the human species, that our collective memory of the scourge of these diseases, it could be so darn poor? Because the fact is, we badly booted the COVID-19 response, and I am happy to engage anyone in a discussion about this. On your left, by the way, is the U.S. government COVID-19 response plan that was published on March 13th of 2020. And I will be very blunt in telling you that as a medical planner, I found this embarrassing. If you read the plan, the approach to COVID, which I'll talk about in detail in a few seconds in terms of its pathogenicity and where it came from. The writers of this particular plan, which were from the Department of Health and Human Services, simply adopted the timeline for the 1918 and 1919 influenza A pandemic, that is 3 sequential waves over the course of 18 months, as the way of describing how they thought the COVID pandemic would play out. Which was ridiculous because if only, in recognition of the fact that we were dealing with an entirely different mutation of a pathogen, and most people who are at least being honest would tell you that we knew nothing about that mutation and what it would end up doing to the human species during this most recent pandemic. But here's what it did do. COVID-19 pandemic was responsible for the deaths of at least nearly 1.2 million people in the United States. I'm not talking about the entire world here. We're just concentrating on the US. That number, and this is going to be a redundant theme in the next 3 points I make, was more than double of any nation in the world by the top 5 nations and 11 other nations that had populations greater than 100 million that would be close to ours. And you can see on the bottom the 5 nations I'm talking about. And think about some of the public health conditions in a couple of those, which on a daily basis are nothing near the quality of our public health infrastructure and healthcare infrastructure available to the population in the United States. This one I find probably the most staggering. COVID killed more people than the cumulative number of Americans killed by every single war fought by the United States in both the 20th and 21st century, again by nearly double. So, forget about Vietnam and forget about Korea and forget about the first Gulf War or Iran and Afghanistan. And that doesn't mean that I'm being the least bit disrespectful to my fellow service members who gave their lives in defense of their country and our ideals. But think more along the lines of the numbers that lost their lives in World War I and World War II. And this should be a staggering number to us that I have been personally surprised has not gained more attention. Finally, more citizens in the United States died of COVID-19 than those killed in the 1918 and 1919 pandemic here in the United States. The total number of deaths for the US in that pandemic was around 675,000. So again, the numbers of people we lost are more than double than that which occurred in the worst disease event in recorded history. So my, again, rhetorical question next is, in this modern age, how could this be? And in the so-called most developed country in the world, how could our numbers be this significantly bad? And I'm going to give you a little bit of my theories about this and then a dose of reality. My first couple of theories, so one theory I say, maybe two, is I think that we generally tend to have something that I recently invented a term for, and some of my friends and colleagues in the behavioral health arena could either take this on or not, but I'll come back to that. And that's psycho-aversion to disasters. We just don't like to stare risk and threat in the face. And it's easier for us as a human species to kind of put our hands over our eyes, put our other arm out at a distance from our bodies and look away and think it just can't happen to me. I've been involved in medical planning after my military career for a good number of years. And most of my efforts have been around trying to help non-military organizations in both the public and private sector, but largely in the private sector, because that's 93% of our national infrastructure, to help them prepare to address any type of risk, whether those is from natural or man-made disasters. And what I've encountered supports this notion of a phenomenon, and that is, if they haven't experienced risk, and more importantly or directly, they haven't experienced the direct impact of a large-scale disasters, their tendency is to say, well, I haven't felt this, I don't know what it feels like, and I don't think it's going to happen to me, so I'm not going to risk anything, or more importantly, invest anything to change their posture of preparedness. We know now, in the wake of Hurricane Katrina, for example, that we can quantify this phenomenon in cost, and that is, for every dollar that is not invested in pre-event disaster preparedness and mitigation, the first two phases of the disaster management life cycle, the second being response and recovery. And by the way, recovery is always the longest and most expensive of the 4 phases of that life cycle. We will have to spend starting at $10 for every dollar not spent. And that can go as high as $10,000 for every dollar not spent. So when you look at events like Katrina that had close to a 18-year recovery, defined recovery period, whose cost is thought to now have run into the trillions of dollars, you can get an idea of how that might have changed if we really put investments in enhancing the level of preparedness amongst a population that we knew was at great risk of this type of meteorological disaster in the first place. The second point I make about my theoretical thinking on this is that we're simply bad students of history, beside all of the information that's available to us in these great books, some of which I'll cite here, and just reading, history as following Mr. Santayana and Admiral Mahan's recommendations, that we haven't learned, or we simply don't want to remember the past. If we don't continue to feel our own vibrational resonance of an event that happened, you know, 18 months ago, how do we expect to feel it with something that happened 100 years ago, where no one is alive that could say, well, I remember it was like this, and this is what it was like to live through. I think more realistically, there's multiple realities, and none of them are that simple. First of all, we simply weren't prepared against what should have easily qualified in terms of COVID-19 as a predictable surprise. That term, by the way, was invented, if you will, by two Harvard Business School professors, Bazerman and Watkins, who published a book of the same name, the subtitle of which is The Disasters We Should Have Seen Coming. Their argument is that all of the signs and warnings, what we call in the military of indications and warning, that we get through intelligence, surveillance, and reconnaissance, all of which we do in public health for monitoring disease outbreaks, that we still didn't pay attention to the signs. The COVID virus, as most of you know, its root is the coronavirus. And if you are a student of public health or know this already, I'm sorry for having to point it out, but coronavirus is as normal appearing in the human species as its near cousin, the rhinovirus. Coronavirus is one of the two viruses we believe most predominantly cause the common cold. The problem with coronavirus is that we knew that it had mutated twice before. In 2003, with the sudden acute respiratory syndrome, or SARS, and then again in 2012 and 13 with the Middle East respiratory syndrome coronavirus, both of which had fairly significant case fatality ratios above the 55% level, which is huge in comparison to any other disease except Ebola in the modern era, at least when Ebola Zaire occurred in 1976. We knew that these things represented disease events that occurred by respiratory particulate transmission between human beings. We knew that they came from zoonotic sources. They were both labeled by the WHO as pandemic capable when the first outbreaks occurred, and for whatever reason that we are still at a loss to describe today, simply disappeared, thankfully, before they were in fact able to rise to the level of a pandemic. That didn't mean that anything related to the root virus of corona was out of our worry field. It should have been an indication and warning to us that if it mutated twice before, there's a very good chance it was going to mutate again, and we should be looking at it in terms of what would it mean by way of a pandemic. I would argue that there are fault lines at every level of the government that were or are broken. You'll see a slide at the very end of this that shows a XY axis and demonstrates in an operational continuum moving from left to right that we basically have three levels of government: tactical level, which equates to city and county; the operational level, which equates to state and regional; and then the strategic level, which equates to federal response. I would argue that none of those people, and I can argue this from a position of experience and knowledge, because I've worked at every one of those levels. We don't talk to each other well. We don't communicate with one another. We have a different lexicon that's used in the developing vernacular of emergency management that is not shared at each one of those levels. So as I'll point out, when we have to cross over into the next level for support, when resources exhaust themselves at the lower level, we're simply unable to communicate effectively with each other. The simplest way I can describe it is that we don't have any commonality in any planning or our approach to planning, nor do we have a planning template that is universal in the United States that, for lack of a better way to describe it, commonalizes the approach we would have to all phases of that life cycle I referred to, preparedness, mitigation, response, and recovery. The next point is that there's no surge capacity in the U.S. healthcare care system. This is largely a result of the fact that since the late 1970s, we have progressed first from diagnosis-related groups as a way to approach how we monetize the delivery of healthcare as a business to managed care, which is the system that is largely universal here in the U.S. and in most Western countries. In the managed care system, beds are viewed as profit centers. So if hospital beds are not filled, the CEOs of hospitals are quickly fired by their boards. And if that happens to continue, hospitals close, which is a phenomenon that we saw in the late 1990s when thousands of beds and hundreds of hospitals across the United States closed because of these very reasons. They were trying to streamline the system to economize the way we approach the delivery of medicine for maximization of profit. And if as long as healthcare is a business in the U.S., this is not going to change. But the translation in our space of disaster medicine and public health preparedness equates to the fact that there's no room at the inn. There simply is no extra resource that we could go to when we see sudden spikes in healthcare demand during mainly large-scale disasters that produce catastrophic levels of casualties. The information management in the COVID-19 pandemic, in a word, sucked. And I apologize if that word is found to be distasteful to anybody, but there was no information management. If only because disinformation up to the highest levels of our government was not only rampant, it was extremely dangerous. And we even found some of our best qualified people, and I will name people like Dr. Anthony Fauci and Dr. Birx, who were trying to give us the best information, being constantly questioned, shot down, and vilified by the population at large because our own government officials were doing the same thing to them and not allowing them to communicate effective strategies to help mitigate the impact of the event. There were political, ethical, cultural, legal, and operational issues that abounded in the COVID-19 pandemic, all of which we had basically learned as far back as an exercise that was conducted 80 days before 9/11 called Dark Winter, which, back to smallpox, we used that as the protagonist agent in a terrorism scenario involving bioterrorism against the United States. That exercise failed miserably. In fact, it was supposed to last for 3 days, and the scenario play broke the back of the exercise in less than 8 hours. That said, we learned quite a bit from it. Not the least of which is that one, the healthcare sector, whose a priori mission in any event is to save lives and reduce suffering, which I argue has to be the a priori mission of any incident management response, especially for events that fall into the category of incidents of national significance, that they are so busy and siloed to individual-based outcomes that they do not work in population-based outcomes, which is the very essence of the public health paradigm. And until we can have our physicians or our healthcare sector understand that there is a breakout as events like this increase in growth in terms of scope and scale of impact, that we're going to change from that day-to-day delivery of healthcare to needing to or demanding to have adequate population-based outcomes, we're not going to fix this. Another issue is that systemically, our healthcare and public health community professionals lack exposure to training in emergency management, disaster medicine, and public health preparedness. Sailors like to tell sea stories, so I'll tell you this one really quickly as indicative of this very point. We were down, we being my colleague, Dr. Len Singer, and I, who I've done a number of disaster response planning missions with, were in Puerto Rico in the wake of Hurricanes Maria and Irma in 2017. And because the Commonwealth of Puerto Rico is an island and they were isolated from the mainland, and the fact that the vast majority, as in 99% of their healthcare and public health infrastructure, were products of the University of Puerto Rico's educational system. When they were asked to staff up and support the emergency support function number 8, which is emergency medical and public health response portion of the Joint Task Force, it was evident to us within hours, if within days, if not hours, rather, that they really couldn't even spell incident management. And I'm not trying to be hypercritical of my colleagues in Puerto Rico, because the answer was very simple, and it wasn't their fault. After about 3 weeks, we were invited to a dinner with 2 or 3 of the lead physicians and one of the nurses, who, before a glass of wine could even be poured, said to us, "The reason we're experiencing this total frustration and our inability to help prosecute the incident management response is because we know nothing about this space." And the argument was, we have not been given so much as a single hour in our training continuum, whether it was medical school or dental school or nursing school or healthcare administrator school, that taught us about emergency management, especially in the post 9/11 era, when we have developed an actual vernacular and a lexicon for the space, and rules and architecture. Some, for example, the National Incident Management System and Incident Command System that we in place during these events, and attempt to follow. But if we have an entire community of professionals that we rely on for what I argue is the most important point, saving lives and reducing suffering, then we are handicapped from the start. Final point to make is that from a national security perspective, we don't get a seat at the table. Medical and public health in the military has historically been something of an afterthought. That changed slightly with the advent of the Force Health Protection Initiative in the wake of the global war, or the Gulf War illness issue that came out of the first Persian Gulf War. But I don't think it's an overstatement to say that we're an afterthought, and we are not invited to be at the table. This was particularly evident given the fact that the previous administration had fired and dissolved the entire National Security Council's pandemic planning and response team in 2018, which meant that there was nobody at the highest levels of our government that were available to provide good information to the critical decision makers at the executive level of government, which led to all the subsequent negative sequela that we saw in terms of the actual response. So, quick, oh, by the way, if you'd like to read, I think a direct coverage of this point, the Naval Institute's proceedings published an article that I wrote in August of 2023 called "Public Health is a National Security Issue." It covers most of the points that we talk about in this presentation, and I argue really pointedly that if you're going to ask the question of why isn't this a national security issue, when you have massive domestic casualties, breakdown in essential critical infrastructure and key resource sectors across the board in both the public and private sectors, actual violations of the democratic process, civil disorder, loss of confidence in government, reduced flexibility strategically abroad, they all occurred. And the fact that nothing else occurred is no small stroke of luck. If any of you have read in depth the national response framework, and particularly the assumptions and limitations portion of it, it notes that in the event of a large-scale disaster in the United States, it becomes opportunistic, and I'm paraphrasing, but this is essentially a quote, for the universal adversary to strike at us with a large-scale act of terrorism, because they know that we have not done well at prosecuting incident management responses to incidents of national significance from 9/11 moving forward to every one of those major events in the first 24 years of the 21st century. So I had to give some time to make sure I'm giving equal share to some of the good points. So we did do some things right, and I cover a couple of them here. First of all, Our experts in infectious disease, virology, and immunology, not only here in the United States but abroad, worked hand in hand largely hand in hand with the global pharmaceutical industry to develop a safe and effective series of vaccines in record time. In fact, I would say that in aggregate, it was probably less than a year before we saw the first vaccines roll out from Moderna and Pfizer, which were effective in reducing the impact of the disease. Remember, in viruses, this is an important side point. You can't treat a virus. You can prevent a virus by using a vaccine, either with a kill protein antigen or a live attenuated virus version of a vaccine. But otherwise, you can only palliatively treat the symptoms of an event, which is why um, pharmaceuticals that help reduce the symptoms are also very helpful and have to run hand in glove with actual vaccine. In both cases, we had assets that did both. And I would think that if we had not been able to do this, or if it took as long as, for example, the measles vaccine took to develop, this outcome would have been much, much worse. And just for the record, it's important to note how difficult this is. One thing that we note in the second bullet here is that viruses change. They mutate. The technical term is that they undergo antigenic reassortment, and their only mission in existence is to most effectively leverage their host, that being us, the human species. So with this in mind, it's often very difficult to develop vaccines because they have to wait for a point when it's hitting sort of, for lack of a better way to explain it, its max stride in terms of impact, um, and then characterize that particular form of the virus at the time as the one that they hope will be the most effective in developing a vaccine. So there are very, very, very big organic challenges to this process in the first place. But I think these two stories are, in this case, success stories. I also want to point that I think the notion of predicting the surge went, and not to be, make a pun here, it went viral. And it induced lessons learned in preparedness in important areas of triage, the use of alternate care sites to address that point of lack of surge, protecting medical staff, and stockpiling critical commodities. It also, reminded us that the importance of pre-pandemic initiatives like the creation of the Strategic National Stockpile were important and will be important in the future, especially on these latter points about PPE and surge. And for the record, surge is not just available beds. My colleague, Dr. Singer, again, likes to say that it's people, beds, and stuff. The stuff being all of the medical logistics capabilities by way of medicinals and equipment and supplies that have to be available to support an affected population. And finally, one of the better things that we've done, at least with the new administration, is that we've reinstalled the Pandemic Preparedness Planning Cell on the National Security Council, and it's currently being run by a retired two-star Air Force physician who is our point person now in looking at the future and helping to decide how we can best plan to change our future successes. So here's what the future may attend, and this is a key point of my presentation. I think there's 5 major differences from 100 years ago, which was the starting point of our discussion for today's presentation, that all are impacting why we are seeing what I would say is an increase in both the frequency and scope and scale of the impacts of disasters that now occur in the modern era. And again, put your history hats back on with this, because all you can translate this to, points in history that have been occurring, since almost, our stepping out of Neolithic times and the development of towns and villages and eventually communities and cities and everything else. First off, since 1918 and 1919, we have seen a quadrupling of the human population. It now stands at roughly 8.1 billion. So that's 4 times bigger than the PAR was when the influenza pandemic occurred at the beginning of the last century. What does this mean? It just means that we've got more people who can get sick globally, and at the same time, will place increased levels of demand on that medical and public health infrastructure I previously referred to that is not necessarily well suited or prepared to meet those demands. Second, we've seen a rise of a phenomenon called the megacity happen since that term was minted in 1971. By definition, a megacity is a small geographic area where we see population clustering, kind of a public health epidemiological term. It's a dense population that supports more than 10 million people at a time. So what's happening there? Well, all of those people, and let's use New York City or Tokyo or Seoul or any easily recognizable city where that population is exactly that, they're all putting enormous demands on the available critical infrastructure and key resources that are available to them on a daily basis. And as we know, almost all of it is working on a just-in-time basis. So, as Malcolm Gladwell pointed out in his remarkably astute book, The Tipping Point, when we see the environmental duress of a disaster descend, those populations are pushed to a tipping point, and they essentially fall off the face of the mat. And when that occurs, think sort of hypothetically, we tend to see increased levels of cascading events that demonstrate second, third, fourth, and fifth order of magnitude and higher subsequent impacts from the initial event. Think of a rock dropping in a pond where we see the ripples go out, much like a tsunami. The pebble may be small, but by the time that the ripples go all the way to their farthest extent, they become quite large. And in some cases, the disasters that they propel forward are actually worse than the initial disaster itself. Add to this is that we've got vast chronic and immunocompromised populations globally that are already placing enormous demands on available healthcare infrastructure. We saw this classically played out in Puerto Rico. We had a very old population. Think of some of the countries around the world, notably Japan and the United States, where people are getting older and have lots and lots of chronic conditions that are rather easily supported in times of non-disaster. But when disasters occur and the demand for their support resources becomes, questionable in terms of availability, they become a population that descends to bad places very quickly. Add to that, the other ongoing pandemic of HIV and AIDS, where we have vast immunocompromised populations in places like sub-Saharan Africa and portions of the Caribbean. And you can see that this demand already is placing on a global healthcare infrastructure that is hard pressed to meet their needs. Number 4 is the climate change, and this one's probably the biggest. Overall, it's changing everything. For example, emerging infectious diseases, the frequency and scope and scale of other natural disasters like meteorological events, hydrological events, and seismic events. Not seismic events, I'm sorry, but climate change is more than just aberrations in seasonal norms that we see with much greater frequency now, and wonder what kind of effects this is going to have. Before I come back to that, I want to come back to Dr. Bray's book and say if that wasn't enough, I want to point out that he says that there's a single inexorable truth about the spread of disease in the human species, and that is it will always travel along man's lines or man's most expeditious lines of communication. Again, that's a military euphemism for man's lines of transportation. So think about this. In 1918 and 1919, we saw 3 separate, relatively slow waves that were facilitated by the spread of the human population moving west to east on rail and maritime platforms. But in 1920, moving forward, we now have this global intercontinental air travel system, which is how we move people around the world. And the expectation is now that this may become, I've labeled, and again, one of my contributions to the literature is I've labeled the international healthcare or airline industry as the vector accelerant of the next plague or great plague. That is that we will hyperspeed people around the earth, and as long as they are, for at least a time, remaining in a spreading asymptomatic phase of their illness, where nobody's noticing that they're sick yet, they're not going to be restricted in their movement, which is going to facilitate any disease outbreak moving incredibly fast around the world. So this notion of waves, the notion of containment, the notion of quarantine are very fast, if not already, have become antiquated approaches. So what's the future? What's a future pandemic portend? No. I want to talk about the future pandemic. There's really no predictable surprise about what's out there right now. We know what's out there, and we should be very, very concerned, as I note here. Currently, the WHO, along with the CDC, have designated 5 separate strains of influenza A that are circulating as being pandemic capable. The most dangerous of one here is H5N1, which again is the avian strain. And I'll just say very quickly, this is the most dangerous one because we have had, these are all zoonotic sources, by the way. Avian is obviously coming from the wild fowl animals that travel around the world in very predictable patterns. But what's problematic is that we've seen the disease, this particular form, jump into the human species already. And amongst the approximately 686 plus cases we've had since 2006, the case fatality ratio is 63%. That's off the mark. It's off the hook in terms of what that could portend when you match it against the growth in population to 8.1 billion, and the fact that if the attack rate in 1918 and 1919 was 50% of the human species living on the planet at the time, but never went above a CFR of 1.2%, a 63% CFR is apocalyptic. One of the better articles about this appeared in National Geographic in 2006, largely written by Dr. Michael Osterholm from the Centers for Infectious Disease Reporting at the University of Minnesota. And it was combined with some modeling that had been done by, again, Oak Ridge Laboratories that showed if this does hit us in full impact, this will be historically unprecedented. And finally, about the climate change, let's come back to is it's likely to cause thousands, not hundreds, not tens, but thousands of new viruses to emerge from zoonotic sources. Why? Because we're seeing a vast increase in man's contact with animals that we normally didn't have contact with. One of the best examples comes from the most recent outbreaks of Ebola in Africa, which originally started in the Ebola Zaire region of Central Africa, but moved into the most recent outbreaks from 2014 to 2018 to West Africa. Dr. Skip Burkle, who's a giant in the public health world of disaster medicine, humanitarian medicine, opined that it wasn't Ebola that changed, it was Africa that changed. And it's because of all the things that I've just been talking about. Increased transportation, increased contact with animals we previously didn't have contact with as sources of zoonotic infections, the fact that our transportation modalities move much faster. We're having these vastly increased demographic hubs around the world, especially in the littorals, which also are coincidentally the same places that we have our aerial ports of embarkation and debarkation, a fancy term for our major airheads, where people are transshipping on a daily basis. And if that wasn't enough, there's a permafrost issue that's just really come to light in as recently as 2021. As you know, global warming is causing some of the areas of the world that were under permafrost in places like the Himalayan steppes for potentially 40,000 years since the last great ice age, and then the glaciers that are rapidly receding. Recently in 21, a number of scientists had been in the Himalayan steppes and found 28 different, I'm sorry, 33 different viruses in the soil after these glaciers had receded, and 28 of them had never been previously detected or matched to a current virus family, meaning none of them could be related to any known viridae, the Latin term for a viral family, such as hemorrhagic fevers, filoviruses, influenza, or any of the other great viruses that have caused significant impacts among the human population for time immemorial. So this is something right out of a Michael Crichton scenario, where they're able to extract DNA from long deceased or extinct dinosaurs. We're finding that these viruses can live and live for a very long time in suspended animated states. But now, as the weather changes and climate is changing globally, we may be looking at the arrival of viruses we simply have never seen before. So what are we going to do about this? Well, I'm going to plow through this pretty quickly. I know we're getting close to time, but the UN disaster folks say that there's no such thing as a natural disaster, only natural hazards. Disasters occur when we simply fail to prepare. But what we do in terms of their severity, what we do against their severity is entirely dependent upon choices that we get to make on our lives, our property, and environment. If we choose to ignore them and fall into that almost pseudo-syncopic posture that I talked about earlier, where we close our eyes and we look away, then we're not going to change this paradigm, because every decision we make will either enhance our posture preparedness or conversely degrade it. And their call sign, if you will, which I think is great, and I love this line, is that disasters occur at the confluence of where hazards intersect with vulnerabilities. If you reduce the vulnerabilities, you reduce the impact of a disaster. And if you want a modern demonstration of that, about 2011, there was a very significant cyclone that hit the Philippines that caused in the neighborhood of 25,000 casualties, including a very significant number of deaths on a specific island in the Philippine chain. When that exact weather pattern was appearing to repeat itself 2 years later, the provincial president living in that area of the Philippines decided to move the population at risk. He basically evacuated all of the people in the predicted modeling path of where that cyclone was going to occur. Instead of 25,000 casualties, they had one. So this is a marker for that point. If you reduce the vulnerabilities that live in our homes, amongst our persons, in our communities, our neighborhoods, our states, and our country, then we're going to reduce the impact of disasters. There's just no other way to look at that. So how do we break the current paradigm? First off, we have to stop treating them as these things that I referred to earlier as predictable surprises. They occur. They're going to occur. They will occur with greater frequency, as I pointed out. Their impact is going to be worse. Some of them have seasons, for heaven's sakes. There's a hurricane season. There's a wildfire season. And yet I've heard people in the media and in government say, oh, I'm just not sure what we could have done. It's so terrible, the impact. If we would have just known what was coming. And I can never understand how people can say that when we know, for example, that the hurricane season lasts from June 1st through November 30th of every year. So we must embrace a culture of proactivity. We also have to recognize that the single common denominator to all disasters are human casualties. I'm not trying to upset anybody who's got a high allegiance to their pets, but humans have to come first. And if that's the case, we have to recognize that no other portion of our nation's healthcare infrastructure is going to bear a more preponderant weight in either adjudicating the successful or unsuccessful outcome of our incident management efforts than primarily the medical, and to a near equal degree the public health infrastructure that is again looking at these things from a population-based outcome. So how do we resolve these problems? First off, I already mentioned these. These are the 8 pillars of catastrophic casualty management. At a minimum, we, when we do write plans, must include depth in addressing all of these areas, because these are the areas, and this is not meant to say that this is of any exclusivity. I've had my students, for many years, I asked them, primarily at George Washington University, it's not an inclusive list. What would you add? And many of them have great things to add to them. But what I'm arguing for is that if you at least focus on these 8 areas and develop executable plans to address them that are shared and collaborated with others outside of the medical and public health arena, your chance of achieving mission success by way quantitatively, if alone, of saving more people and reducing the impact that they might suffer, I believe can be improved. From a tactical perspective, this is something that we need to look at from right down to the very hospital and healthcare systems that now populate our nation. One of the ways of approaching this comes out of a theory called network-centric warfare that existed or that was initiated by a guy named Art Zebrowski, Admiral Art Zebrowski, by the Navy, from the Navy in the early 2000s. Zebrowski's theorem and initiative was very close to what is now very popular in American healthcare in the preparedness arena, and that's coalition initiatives, where we are developing networks under the premise that we know that if we stand alone as an individual silo, we run the risk of collapsing under the weight of an event. So added to that was we have to plan for alternative standards of care that shift from these individual-based outcomes to population-based outcomes. We have to look at alternate care sites in our counties and communities. COVID proved that our hospitals as static brick and mortar facilities are never going to be able to meet the demands that we will see with large-scale disasters. We have to plan for pharmaceutical and supply distribution, which becomes increasingly problematic as very specifically disease events increase because of fear and because of the fact that the very people we're relying on to do these distribution are going to be impacted themselves. It's kind of another phenomenon that we see fairly often, that the healthcare community and people who are involved in a supply chain on the healthcare side and specifically the pharmaceutical industry are somehow immune from these events. They're not. They're part of the general population and they're going to be affected by them too. We have to expand staffing, supply, and capabilities, develop consistent and actionable plans, and collaborate with each other to develop mutually formalized support agreements, almost like an extension of the emergency management assistance compacts, or EMACs, that are used in general emergency management in the United States. But I argue that success is most readily going to be achieved by engaging in deliberate planning prior to any of these disasters occurring. So to that end, here's my most important admonition. Every community, and not just the emergency management community or the healthcare community or the public health community, must engage in deliberate planning ahead of any emerging threat. Deliberate planning is a phrase that's born directly out of the military and our war planning through a very important systemic approach we call the Joint Planning Execution Enterprise, the JP. But it means that you're looking at all of the contingencies and addressing the challenges you're going to face ahead of the event occurring, with the premise that you're never going to be able to catch up with them once the event starts to move forward in time. So I basically come up with this quote, which, hubris aside, is sometimes being referred to as Marghella's law. And the law is that by failing to engage in pre-event, that is pre-disaster deliberate planning, your chances of mounting a successful incident management mission response decrease in equal but directly inverse proportion to the scope and scale of the event. If you've ever heard of Occam's razor, born from a quote from a guy in Great Britain named William of Ockham in 1346, which argues that all things being equal, that which can be done with less is done in vain with more. This approach comes right down to this core axiom, that by failing to plan, you're planning to fail. And there's no other way around it. Once the event starts, nobody's ever going to be able to catch up. And I finally put up this continuum that I referred to earlier as a graphic. And I want you to look first. I always get these wrong, but I think this is the x-axis. This is the y, maybe reversed. In any event, the vertical axis is the inherent capacity for casualty production for any type of event. Pick a disaster, any disaster. There's an axiom in the emergency management community that's existed as long as they've existed. That is, all disasters, at least at their start, are local. So we see this event occurrence signified here by my cursor circling event, starting in the corner at the confluence of the XY axis and then moving up at a higher level to demonstrate what the event magnitude happens to be over time. It builds. So what I argue is that when you're at these lower levels, and again, my point is we lack a common preparedness and response architecture. We currently lack any commonality of planning. We lack a commonality in our lexicon vernacular and the terms and words we use in different communities. Some communities are afraid of talking to other communities. I can't tell you how many times I've heard emergency management people say, well, I can't talk to the doctors because the docs speak a different language. It's that medical stuff. But what I'm demonstrating here is that in large scale disasters, as resources exhaust at the lowest level, invariably we're going to have to go to the next level to get what we need. And two things I want to point out. One is because of that lack of commonality, we see command and control, or what the Department of Homeland Security likes to call in the modern era, the new C2, cooperation and collaboration, break down. There's fractures. So we're almost defeated before we can start. The other thing to point out here is I want you to look at the response times. The notion that anybody is coming from the strategic federal end that's going to be able to pull our chestnuts out of the fire is not a good notion to bank on, because at a minimum, first off, they're not arriving until it's largely too late. This can be encapsulated in something we refer to as the twin tyrannies of time and distance. And I once made a point that if you can't get assets to an affected population, then the population is DITTER. I invented another acronym, just like we needed one in the military. DITTER stands for dead, dispersed, and recovered. And it means that the assets that come from this farthest level of the operational continuum will have no bearing whatsoever on the outcome of those lives and those people who were affected at the micro-tactical level. So this point argues that we have to take planning and preparedness as a personal initiative for ourselves, for our families, for our neighborhoods, communities, healthcare systems, public health systems, our states, and our country, because the white knights that we think we should be waiting on from the federal government will not be arriving. And it's important to note, as a final point, is that it's been only recently that FEMA, the Federal Emergency Management Agency that's responsible at the highest level for preparedness in this nation, is the first to tell you that they are not first responders. FEMA is a check writing organization to provide resources for critical commodities that are needed in times of disasters. They don't have control of forces. So if anybody's waiting on that white knight on the charger to come and pull them out of danger, they're going to be waiting a long time. So it argues that real preparedness, real changes in the preparedness paradigm are going to happen at the most local level. And with that, I have my references. These slides will, of course, be made available to anybody who's interested. And now I am very happy to take questions.
Looks like. So for questions, if you just want to come off mute and ask, or put them in the chat, we'll read them out. Thank you so much. That was a very enlightening talk, and I would love to see what the audience is thinking and wants to learn more about.
Well, why don't I start? Just Pete, this is an excellent presentation. I was taking notes throughout. Many of your quotes, perhaps on every slide, are some real zingers, and I'll with your permission and credit to the author, use them again. But thank you. I think this is a real clarion call to government, the public health community, and the general population to prepare. And again, we used to say within our communities, it's not if, but when the next pandemic occurs. So
Sure.
thank you. I want to congratulate you on an excellent presentation and a very widely dispersed and very credible audience from all over the world. So good job, Pete. Thank you.
Thank you, Dr. Turbush. Appreciate that.
Hi, I have a question. My name's Pat Frost. I'm the vice chair for the National Pediatric Disaster Coalition. Tremendous presentation, especially about the silos that have been occurring and, we grow up with as far as that's concerned, as being in this space of advocating for emergency inclusion of children in both the med health as well as on local levels. I've kind of come to the conclusion that we need to change the culture. And in order to change the culture, we really need to focus on the children. And we're not paying attention to what we need to do with children at a very, very, very young age in terms of making sure that they can protect themselves, that they know what to do, they know their name, they know where they live, they know how to get in contact with their parents, and to all these simple things. Teach them about weather, teach them about the signs of, impending storms. And we have all these kids with mobile devices, and they don't even have, the earthquake alerts or the weather alerts on their phones and stuff like that. There's so much low-lying fruit. I wanted to know if you can comment on that.
Absolutely. Boy, you couldn't have set that one better up for me as if it was an 8-foot, softball tossed at me in the middle of Yankee Stadium. Listen, I'll go right to an example that worked and worked so well. It literally changed the paradigm in the arena of home fire deaths. Back in the 1960s, and again, everything that I'm describing here, us moving towards these mega cities, the move towards suburbanization, the baby boom, the increased number of homes being built throughout the world to accommodate a larger workforce coming back from World War II, et cetera, et cetera. We started to see a phenomenon with a marked spiked increase in home related fire deaths. So the National Fire Association looked at this and thought, gosh, we've got to do something about this. So what they did was they approached some professional educators who explained to them that there's this process called repetitive admonition that could be used. And for our physicians and physiologists out there, we have a portion in our brain, as you know, called the amygdala, which is not only scarred by events like PTSD or horrific events that cause PTSD. The amygdala is also a place that we store things like repetitive admonitions that we'll remember for a lifetime. So in this case, what they came up with was the Stop, Drop, and Roll campaign, where they targeted K-6 children in public and private schools throughout the United States. They had a representative from the local fire department come, and they would have them sit through what was essentially 6 hours in aggregate of fire safety training. And they learned about how to have rally points for their families. They learned about rope ladders. They learned about stop, drop, and roll, which was shown to be very effective in stopping, fire on a human person, et cetera. And what happened, what phenomenon in this case positively occurred, was there was a 77% reduction in home-related fire deaths within 2 years in the United States. All accredited to this fact that stop, drop, and roll stuck in people's mind. And if you're, a baby boomer and a child of 60s like I am, stop, drop, and roll is right here. So we actually wrote a paper, we being one of my colleagues who wrote Disaster Preparedness for Dummies, Maurice Ramirez. And we wrote an article that appeared in the Journal of Homeland Security called "Now Children Repeat After Me." And what we wanted to induce was a repetitive admonition for disaster preparedness and how to increase hygienic initiatives. Lather, rinse, repeat was our admonition. Because we know that transmission occurs when people do things like shake hands or get too close to each other, and that enhancing hygienics will change the increase of the spread of disease or cause the decrease. So we sent it to the U.S. Department of Education. We sent it to the Department of Homeland Security. We sent it to the Assistant Secretary for Preparedness and Response at Health and Human Services. Crickets, nothing. So I couldn't agree with you more that we are missing out on a population that, and I apologize to anybody who takes this as a too religious a term, but children tend to be messianic when they take on an important thing to remember, especially as it relates to the safety of their parents, themselves, and their siblings. And that was proven in spades with the Stop, Drop, and Roll campaign. And I believe that there's still merit in the approach, and it could work because they are a population that will tug our sleeves and say, "Mommy, Daddy, are you doing this? Do we have a rally plan? Do we have an egress plan? Do we know who to call in times of emergency? Do we have a go bag that will give us critical resources to protect us? Are we stockpiling water and non-perishable foods in the basement?" And if we could do that, it's almost like a Back to the Future on civil defense in a way, which had us a lot better prepared during the height of the Cold War than we are now. And in fact, I would add that if we did a Back to the Future initiative on both counts, leveraging a repetitive admonition program and reinvigorating a civil defense program for the United States with a focus on medical and public health surge, we could change our readiness capacity pretty quickly. But it requires an investment in time and money and effort, and that's at the end of the day always the issue. But I'd rather see us doing positive things like that than throwing money out the window with Dick Tracy wristwatches that were the norm in the wake of 9/11 than doing something that we know has proven efficacy. Great question or comment. Thank you, Patricia.
Thank you so much. There's a couple questions in the chat, but before I saw Carol Stewart had raised her hand, so I would inviting her to come off mute and share her comments and questions.
Good morning, everyone. So I'm joining you from Aotearoa, New Zealand, and thank you for a fantastic talk. I really learned a lot. So in New Zealand, our COVID response was generally held to be one of the better ones in the world, and our fatality rate was something like 5 times less than that of the United States. Mm-hmm. And this was largely due to the strategy of closing borders and keeping the virus out completely until the vaccine was available, which helped hugely. So I teach a course in disaster environmental health here, and I've just put a link in the chat to a report that was released here a couple of days ago, and it was a government inquiry into our response to a massive cyclone that we had last year, Cyclone Gabriel. So last year we were hit by a series of extreme weather events, and they affected, the scale of them were enormous, quite similar to the Queensland floods in 2010. And it's a really good report, and it emphasises many of the things that you were speaking out, Pietro, about the real improvement can only come from the local level. And some of the best responses were in our Māori communities who live in some of the really at-risk areas. And so Māori communities are really, they've got community structures called marae, which are sort of meeting houses, and they tend to have things like big industrial kitchens and bathrooms, and they're ideal for emergency response and community hubs. And the reports recommended that they step up in times of disaster because that's what they do, but they need to be properly formally included in the emergency management system and resourced properly to do the job that they do anyway. And the report's full of recommendations about strengthening the local level. And I think what you said about real change coming at the local level was absolutely spot on. So I've just put a link to that report if anyone's interested. And yeah, thank you all, and it's really nice to be here on this chat.
So thank you for your comment, Carol. I'll just make a couple of quick comments. One of my very well respected colleagues, General Donna Barbish, a Nurse Corps officer who rose to be the Assistant Secretary of Defense for Chemical, Biological, and Nuclear Preparedness, argues that one of our negative cultures is we're a culture of lessons learned, and Donna has argued in her contributions to the literature that if you look at the lessons learned from disaster to disaster, what changes is the location, the names of the disaster, but virtually the lessons learned are all the same. You can just take the old report, put a new title on it, put the new event in there, and you've got yourself a shiny, brand new lessons learned report. On the other hand, best practices are a horse of a different color. And there are nations in the world, notably like New Zealand, who are demonstrable success stories. And we should be listening and studying their efforts and actually pull what can be used in our own environments. It's always going to be different, right? Their communities are different, our nations are different, but there are commonalities that have been shown to be effective and useful and utilitarian in these types of events. And we would be well served to read what they did in hopes that we can learn to apply those for future events. Carol also used a really important word, and that is resourced. And I just want to make a real short comment. We don't do planning well, and even when we do planning, most of us miss the most important part of the planning process. At the end of a planning cycle, for example, in the military, deliberate planning cycle, which used to be 2 years, it's now 1 year post 9/11. Planners at the combatant command levels, which own the global war plans, would say to the chairman of the Joint Chiefs and his staff, "Here's our plan. Please read it. But more importantly, here's the list of the stuff we need to execute the plan. Now take that to Congress and get me a portion of the assets I need." That's the resourcing process. And a lot of us, do plans, and we take a plan after lots of effort and we put it on a shelf and we say, "Look how nice it looks. It's thick, so it must be meaningful. And look how much effort was put into it." But unless you extrapolate out from those plans the actual requirements and capabilities to execute the mission, and then put dollars behind them to have them come into existence, your planning efforts are moot. They're for naught. So I think that word that Kara raised is very, very important for us to consider. Because it's something it's a disconnect between us and our comptrollers in various agencies. In that, at the end of the day, we might say we need stuff, but until we hand the bill of lading to them, we're not going to get it. And then when push comes to shove, and the assets are needed to be called in, they're not there for us. Thank you for your comments, Carol.
And then from the chat, we have Anani Prosper saying, "Thank you for this presentation. Do we have a set of warning indicators for emerging diseases?"
I would say in aggregate, no. In fact, from my personal experience, including time spent at CDC when I was involved with planning efforts in the mid early 2000s, I never knew how to say the 2000s, right? It's, 2000 to 2010. One of the things we heard a lot about was that the CDC and Health and Human Services had funded something like 50 disparate surveillance systems. And the joke was that they were kind of waiting to see which one would work. It's not a good joke, but they were kind of banking on let's see which one shows that the best return on the investment, and that's the one we will universalize. We've never come to that. So there's two issues that are being brought up here. There's the surveillance and report. There's three issues. It's the surveillance and reporting is one that drive us to action, and the other is global medical intelligence. I recently participated in an international program on global emerging infectious diseases with a very erudite group of people from a think tank in Washington, and this came up that while we have an organization called the National Medical Intelligence Center here in the United States, even that has flaws because it's largely only accessible by military personnel because it's a portion of the Defense Intelligence Agency, which is a subset of the Central Intelligence Agency, which in many cases mandates that people have access and clearance to see the stuff in the first place. And two, there is no equivalent at the global level under, for example, the aegis of an organization like the WHO that allows us to adequately share good emerging medical intelligence to drive our planning and response efforts. So I would argue that right now that this is still a gaping hole that needs to change. The only thing I would say that we've seen improved, and it's kind of serendipitous, is that because of the availability of the World Wide Web and the very rapid transfer of information, largely in open source that we all experience on a daily basis now, we can get some of that information through asymmetrical, sources. DHS, for example, has a Department of Homeland Security in the United States has a whole wing, if you will, who has people dedicated to sitting in front of computers and looking for keywords that are being pulled out of people's conversations and tweets and Facebook posts and open source things. They're not getting into people's lives and brains, but they're picking out these words that people post, and that is helping to expedite their response. The great example is when the gentleman from West Africa showed up in Dallas at the Catholic hospital there, displaying signs of Ebola that wasn't recognizable to the hospital emergency staff at first. One of the nurses tweeted, "I just had a guy come in from Ghana or Sierra Leone." And that actually activated the CDC, Epi Intelligence Service, and the folks in ASPR and the intelligence agencies ahead of any official reporting that went through the MMR, the daily or weekly morbidity and mortality reporting system that we currently use. So I think this is one of the extant challenges that is still out there for us, and it will always be a little bit on the hard to overcome level because of the fact that we don't get along with everybody. I mean, China and Russia, are, we have our issues with them currently. We worry about the quality of the information that we might get them in terms of what it represents by early warning systems for us to leverage quick response. So I think we're going to continue to see challenges in this space, and it's using this term too many times tonight, but it's another greenfield opportunity for smart people to start thinking about how do we change this current paradigm.
Great. And then one more question from the chat. What is being done to assure that basic preparedness and healthcare curriculum is required in part of professional licensure testing?
At the moment, I think nothing is my subjective impression. In fact, the president of WADEM, Dr. Don Donahue, has spent no small amount of effort and years trying to inject issues related to medical and emergency and public health emergency preparedness and response into curricula in the various allied health sciences programs. And the pushback that we always get, and I've heard this argued, even we had a document in the 2005 or 6 timeframe called Homeland Security Presidential Directive 21, or HSPD 21, that was driven by concerns of a near-term emerging pandemic, that basically tasked organizations like the Uniformed Services University, which is the federal medical school in the United States, to develop enhanced curriculum or initial curriculum on disaster and emergency response. And to this date, we still don't have a dedicated MPH program at that university or many other universities. I'm only aware of 2 in the United States with a dedicated medical and public health disaster management program. We have a ton of emergency management programs that came out of the woodwork after 9/11 because the Department of Homeland Security, funded them and felt like we should be enhancing emergency management. But the medical community didn't get the same benefits of those initiatives. And I think until leadership in the healthcare space recognizes their role, which is still questionable because an organization like the American College of Healthcare Executives, ACHE in the United States, which has basically about 98% of all the CEOs and C-suite executives in the 33,000 plus hospital in the United States as their members, refuses to put curriculum into their annual training material or annual congress related to disaster preparedness. So I'm not sure how we change that. I think it's another groundswell initiative that the rise of an organization like WADEM, which can serve as a lobbying organization to institutions of higher learning in the healthcare and public health space, can hope to invoke change in.
I will just quickly add that one of the reasons that the Student Young Professional Special Interest Group under WADEM exists is to serve this purpose, to supplement the healthcare curriculum.
Exactly.
So if you know young professional students, you can point them towards us if you are looking to kind of bolster their education in this sphere.
Thank you, Alana. Very good point.
Okay, great. And we have a couple hand raises. So I'm going to invite George Tataro, sorry if I butchered that, to come off mute and share his questions and comments.
Thanks. You almost get the name right. Thanks. One question for you, Doctor. How good are we getting at standardizing communication? Because one problem we have in England at the moment is same thing, same word means different things for different agencies, like ICC, like ICU. So are we getting close to standardizing communication in disaster management?
I think we're making progress, George. I refer to this as the NATO conundrum. Back when I served in the NATO community in the mid-90s during the Bosnian campaign, we had 18 nations. And it was a not so funny joke that none of us, either spoke a common language or had common approaches to our planning, even though we knew that under the aegis of the NATO organizations, we'd have to commonalize everything. A real good example was we standardized the size of the litters we wanted to use in NATO if we went to war in Central Europe, but we didn't standardize the litter stanchions that went into the airframes for medical air evacuation for patients. So with that said, I think we're making progress, if only for the fact that I come back to that since 9/11, which really I think changed people's perspective on the notion of increased scope and scale and frequency of disasters, that we had to bring emergency management and our colleagues in the medical and public health sector dragging along to say we have to formalize this. We have to create architectures like NIMS and ICS that are common and that will be used universally. We have to invent language that applies to what we do. We have to invent theories and constructs for incident management strategies, especially at large scale levels. It's, for example, we need to think now in the world of our current threats about national incident management strategies, where we could have entire geographic swaths of our countries affected by large scale disasters. And all you have to do is look at the Indonesian tsunami to underscore my point in that. So I think progress is being made. And again, WADEM, as an emerging organization dedicated to this space, is going to be, I'll use the term again, a vector accelerant for us in getting us to a more common place where our approach is universal. But like everything, there's still a long way to go, I think, George.
Thank you.
Thank you. And then Helen Engel.
Well, yeah.
Sorry.
No, you're great. You're great. Hello, everyone. I'm a public health veterinarian from Western University of Health Sciences in Los Angeles. And I wanted to speak a little bit to the concept of the vulnerabilities that you mentioned, Dr. Marghella, and it's just a real pleasure to hear you speak directly. We in the veterinary community have been very concerned for a very long time about the lack of biosurveillance across some of the species where these spillover events are causing the emergence of pathogens in humans. We very much think that when we're having this conversation and it starts from the human perspective, we're missing an opportunity. Many in our community talk about a species neutral approach to biosurveillance. And if I can just speak 1 second to that in terms to a room full of perhaps primarily physicians and emergency preparedness folks, there's very little companion animal surveillance in the United States. There's livestock surveillance because of foreign animal diseases and the implications to our food security. There's a tiny little bit of wildlife surveillance, but I'm not sure that people in the room realize that all of those companion animals that we interact with daily that are effectively sentinels or can be sentinels for something happening in our local community, there is very little mandated surveillance of that. And so what I'm interested in hearing from you, Dr. Marghella, is how much veterinary engagement have you had in your emergency preparedness discussions? And one thing I'll just say, but before I have you answer that, is you should be heartened to know that in my curriculum, all of the veterinary students get ICS training. And of course.
Good. So Helen, first off, I couldn't agree with your comments more. The veterinary community is an absolutely vital link, and it to the broader medical and public health preparedness community, and on the notion of being almost a principal sentinel surveillance network resource that's available to us. We have to do a better job pulling them in. We simply can't look at them under the concern of purely the economic impact of disasters like foot and mouth disease and others that might affect the sale of meat from the cattle industry. And you know, it only seems to get to the attention of somebody like Oprah Winfrey when it's at that condition of economic concern. On the other hand, if you take seriously my point that with climate change, which I think you do, we're seeing greater interaction between animal species and humans, it's a default likelihood that is where zoonotic sources are going to see an increase in causing disease, making special jumps into humans, and with all of the attendant problems. So we do have to do a better job. My admonition to anybody is it comes back to the silos. At a program called the National Preparedness Leadership Initiative or Institute at Harvard University, started by David Gergen, the Dean Emeritus of the Kennedy School, they introduced the theory of siloization. And one of the important points about the theory is they use this great demonstration. It's 5 or 4 vertical silo-looking, entities on a piece of paper, and they point out that independent of one another, the silos are always competing against each other for attention and money and power and et cetera. They exercise leadership in a vertical, top-down, top-heavy continuum, and what they argue is the verticals as silos should not go away because they all provide a discrete and important positional resource to the greater community at large of this preparedness and response mission. What they argue is that there needs to be a meta leader that comes in the form of a person, an organization, or a policy that brings those disparate entities together for a common purpose. And the veterinary community, if only because of this issue of increased zoonotic sources causing more risk of future and more aggravated pandemics, has to come into the fold. And that's only going to occur when people from the community argue, you got to listen to me. I have to be at the table as much as the public health community has to argue that they need to be at the national security table at the National Security Council if we're going to be heard And we're not going to wait for really bad stuff to happen before we say, God, I really should have talked to them in the first place. So I hope that answers your question.
Thank you. Yes.
And then our last question is going to be from Mark Voice. I just want to say, if you have any other questions, feel free to follow up with the student SIG and we will direct it. So Mark, if you can just come off and comment and question, that'd be great.
Mark, I can hear you.
So my two disclosures are I'm an adolescent psychiatrist and I'm a multi-decade member of the Physicians for Global Survival, IPPNW, etc. So I'm thinking of psychoaversion. I'm thinking as a psychiatrist, with all due respect to the magnitude of how we're talking today, I wonder if psychosis is a better word, as in the coughing into your elbow, stop, drop, and roll. So I think everybody has heard the phrase, one of the definitions of insanity is doing something over and over again that's not working. So the Physicians for Global Survival have actually put almost all of their effort not into building bunkers, preparing, having lead shielding, because they've concluded, and I have to say, listening to your talk today, I'm not impressed with my survival under, and I live in Canada, Toronto. I'm worried. This is not good, but I'm just a little less worried that I'm about nuclear war, because you're saying virtually when the stuff hits the fan, you're on your own, buddies. Like this is, there's no white knight coming down for you. So my two aspects to the questions are, what do you consider would be an appropriate response to the mindset of people, as in, are we just being a little, we need a nudge, you know, great psychoneurological term. We need a little nudge, we need a little reminder, we need a little history lesson. We need to be kind and compassionate and arouse people to attend to the fire that's burning their butt off. Or should it be the type of mindset response that deals with psychosis, to wit the stress of us medical professionals who are dealing with people in their dying words saying, it's a hoax. This doesn't, you know, COVID, no, it's a scam, it's a conspiracy. And they're dying words, which, not to say they didn't pay the price of death, but that was really, really distressing to a lot of healthcare providers.
Yeah, Mark, I would, you know, there's another side of that, you know, near death and still, you know, denying the reality of an ongoing pandemic when one is actually suffering from it and is being propelled to their own mortality in the first place. The stories that I've heard, you know, have to do with people who have been deniers from day one, about to be intubated because they're on their very last leg, and their last words to the intensivist is, "Can I have the vaccine, please?" And of course the response is, "Yeah, even if I gave it to you, you wouldn't build a level of, you know, immunogenicity that would be sufficient to protect you at this point." What they're not saying is you're going to die, but that's what was happening. I think there's a fine, you know, first off, I go back to Dr. Turbush's comment, and I'm glad he made it, because I should say it in every one of my presentations. It's really not if, and it's not picking a disaster, any disaster like, you know, the next pandemic. It's not if, but when. I for years have done a presentation called It's Always 9/11. And I ended by saying, you know, just like on that bright, clear, beautiful Tuesday morning at 8:46 and 38 seconds, it was a bright, clear, beautiful Tuesday morning. A second later, the entire world, you know, turned on a dime and changed on us, and nothing has been the same since. From a, you know, I'm, for the record, you know, not a behavioral scientist. I absolutely appreciate the role that the absolutely important role that the behavioral health community plays in this space, especially on this issue of, and forgive me if I'm not phrasing this the right way, buying into the fact that these events hang over us as a global human population, much like the sword of Damocles on a daily basis, just in varying degrees. I don't argue that people become preppers, because just like everything in the bell curve, you know, the extremes on either end are largely useless. And in the prepper community, God love them, you know, they tend to isolate themselves and will shoot at anything that wants to come near them for fear that they're going to take their resources. That's an extreme. On the other hand, doing nothing is a recipe for, pun intended, disaster, because if you've done nothing to protect your own sphere of influence, that is your own home, your own person, you know, by simple things like vaccinating against emerging diseases, for example, and wait to see either what the outcome will be or what others will do, you know, including how they might help you when, you know, the proverbial stuff starts to hit the fan, you're in for trouble. So my argument is, don't wait for higher levels of organization to come and help you. Do enough to give yourself some increased level of enhanced posture preparedness for yourself and the people you care for, your family, so that at least for some period of time until outside resources are able to come in, you've got things that can sustain you. And they always come back to the basic commodities of life: access to water, access to food, access to shelter, access to some sort of physical protection that is going to keep you safe from harm for as much time that can be afforded to you.
So I look forward, I love your element of history. I look forward to one of your talks. I'm going to give you the title, Cultures That Extinguish Themselves and What We Can Do to Prevent It.
Thank you. Good point. If you read that smallpox book that I introduced at the beginning, Mark's not too far off. There literally have been empires that have gone away as a result of disease. And I'm a war college graduate, and you know, we start off with strategy and policy. We start all the way back with Thucydides and the Peloponnesian War. You know, is one of the most recognizable first recorded incidents in history where we have good records. And the Athenians lost to the Spartans because of a massive disease outbreak that most think was either bubonic plague, or I tend to think it was a smallpox outbreak. But we seem to have failed, you know, recognizing the impact of disease on our cultures and our civilizations. And I'll end, if that was the last question, with a quote from Will Durant, the great historian, pair with his wife, that said, "No great civilization has ever collapsed without first allowing itself to collapse from within." And you could take that from a political perspective, or you could take that from, you know, the dangers that are inherent in our environment today. If you're not going to do anything about it, it should be no surprise when your life as you know it, your community and your country as you know it, you know, becomes a loud sucking noise because we just failed to take into account that these things occur. And with all of the factors I've enumerated today, are occurring with greater frequency by ways that we really can't prevent. This is a natural progression. The British economist Thomas Malthus in the 17th century had something called the Malthusian prophecy, where he said at some point we're going to exhaust the resources as humans of what this earth can provide for us. And most treated him as an extremist. But if you think about it, you know, with the way we're growing and moving forward so fast, if we don't take the time to think about, you know, what's out there that does the human species harm, I think we're all going to suffer the attendant consequences. So with that, I think we're just past 7, quite a bit past 7. So I want to thank you very much for your time and attention. I do hope you enjoyed this as much as you can enjoy a subject like this, and at least found it somewhat informative and helpful to your own professions and efforts that you're making on a daily basis. And for all of that, I want to thank you. You wouldn't be here if this wasn't an interest to you. And I know many of you have devoted your lives to preparedness and healthcare and public health. And God love you. Thank you.
Thank you so much, everybody. Have a good night. If you have any questions or further follow-up, you can find us at wadem.org and our email student@wadem.org. Thank you so much. Have a great night.
Thank you.